presenting time since injury is the major factor in preventing tranexamic acid use in trauma setting. An observational cohort studied from a major trauma center in a middle-income country. Hemorrhage is responsible for about a third of in-hospital trauma deaths. The CRASH-2 trial demonstrated that early administration of tranexamic acid, ideally within 3 hours, can reduce mortality from trauma-associated bleeding by up to 32%. The aim of the study was to examine whether in a middle-income country trauma setting, patients arrived in hospital soon enough after injury for tranexamic acid administration to be effective and safe. It was a prospective cohort study of 50 consecutive patients over a 3-month period admitted to Kritiski Hospital Trauma Center. As for CRASH-2 trial inclusion criteria were systolic blood pressure of less than 90 mm of mercury and or heart rate of more than 110 and injury suggestive of a risk of hemorrhage. The patient with isolated head injuries are excluded. The mechanism of injury, time since injury, and any reason for delay were recorded. Out of 50 patients, 47 were men. Mean age was 32 years. 26% patient presented within the time frame of 3 hours, out of which only 6% patient presented to our trauma center within less than an hour of injury. 22% patient presented after 3 hours of injury, and 52% patient were unsure about the time of injury. The reasons for delay who presented after 3 hours was delayed presentation to medical care, long transfer to hospital, and found in the road with unknown time of injury. So in conclusion, the majority, 74% of our bleeding trauma patients do not present within a time frame that allows for safe administration of tranexamic acid therapy. So tranexamic acid should be added to the pre-hospital arena if maximum benefit is to be obtained. Thank you.
I'm not surprised Dr. Hardcastle wants to say something.
Just to comment that problem, in some respects, if we're going to look at employing TXA, I'm not entirely convinced that the evidence is as good as what the CRASH-2 trials made it out to be. I'm sure some other people might comment on that. But what would be a problem here is that same 70% that are unknown duration from injury would still not qualify for TXA, because the requirement for TXA is that it has to be a known injury within 3 hours. So it doesn't matter, that 52% group is not going to be affected if you give it to the paramedics or not.
Can I just add to that? So your first slide is actually incorrect. The reduction in mortality is not 32%. That's a relative risk reduction. Absolute reduction in mortality is 0.8%, which gives us cause for concern when you're interpreting their data. Also, do you really think you have enough data to advocate it in the pre-hospital arena? When the entrance criteria for CRASH are very soft, and there's 2 studies now showing a 9-fold increase in DVTs and pulmonary embolus using tranexamic acid.
Any other questions?